Okay, we'll be talking about the international and national circumstances. As you can see, we still have a 76% distribution of cases that has been sustained throughout the last 14 days. If you remember the conference we've participated in the past, we can see the rhythm has maintained. Now, up to this now, we have over 750,000 cases that have been confirmed worldwide. Now we can look at the national statistics. We have 1,215 cases confirmed. We have added one death since yesterday. And you can see the distribution of the cases in which the highest concentration is marked by yellow in this case, and the lowest concentration is light green. We have continued to examine all of these cases from the moment they are suspected to be positive throughout confirmation and recovery. Now we can look at this chart, which is a little similar to the one I just showed you, but that was a map. This one is a chart form, and we're basically looking at the highest concentration according to states of Mexico, and we want to present it in this way because it's quite a contrast with the following slide. This slide that we're showing now is the accumulated incidence rate. Not the same thing to have 10 cases in a population of 10 million than to have those same 10 cases in a population of 10,000. So with this indicator, we can know the proportion between population and confirmed cases. As you can see in this chart, state of Mexico and Mexico City, they had the highest density or the highest number of confirmed cases, but when we take into account the population, then we can see there are different states. In this case, Quintana Roo state is the one with the highest density of confirmed cases per population. Yeah. And Mexico City is also there. Meanwhile, the state of Mexico is really not a significant state within this chart. So all of these charts you can look at them, and this chart, we will be showing this chart as a frame of reference in each of the daily conferences that we will be conducting here. Now we have the sex distribution of confirmed cases of COVID in Mexico. 58% have been male, 42% have been female so far, and this matches the relation that we've seen in other countries around the world. We can notice that underage population does not occupy a significant place within the chart. Next slide, please. Now we can look at the distribution by age, and now we are talking about the proportion between walking patients, so to speak, and patients that have been hospitalized so far. But we can see that this 16% of cases had to be hospitalized at some point, and those cases have also concentrated. Those cases are represented by the yellow bars, and basically they have a direct relation with age, with an increase in age group. So the higher the age group, the higher the rate of hospitalized cases and hospitalizations needed. And By contrast, most of the cases that are walking, that the patients didn't have to be hospitalized, they correspond with younger populations and they didn't need a more aggressive or more monitored treatment. They just isolated themselves into their houses and they were fine. Now we can look at the evolution of the hospitalizations. So out of these 16% of cases that had to be hospitalized, we have a 5% that had a high risk, and 1% had to be intubated, which is an even higher risk that could lead to fatal consequences. Now we can see the distribution of the deaths that we have had to deal with so far, and this is also attending to the criteria of sex distribution and age distribution. We can see that most of the deaths have been male, and only 10% have been females, but out of these 10%, most of them have been in the older than 55-year-old age group. So once again, we see how being in the higher age groups is a risk factor when determining the severeness of COVID infections. Now we have this chart in which we can look at the different deaths that we've had so far, and they are distributed throughout the different states of Mexico. I think tomorrow we could present to you a more sophisticated, more illustrative chart regarding this distribution. But if we look at this, we can see that there are differences between states when it comes to mortality rates. Now we have this other chart that are about the different risk factors presented by all these 29 fatal victims. Top three are hypertension, obesity, and diabetes, which we know that are the three key risk factors for that could lead to complications or even death when being infected with coronavirus. But we have others that are whether the patient was a smoker or not, kidney failure. So if you see all of these risk factors, they match the health measures that we've been implementing in order to protect these vulnerable populations throughout the country. Now we have this curve of accumulated cases so far that to this day is 1,215 cases. And of course we will continue to see the curve spike up as the days go by. And COVID cases continue to be confirmed on a daily manner. If we can contain this through the proper measures, then we'll see the curve flatten. Now we have this same curve, but we are comparing it to the behavior of this phenomena in other countries. So as you know, March 23rd, we started the national program for safe distance, and more recently we have been implemented the sanitary emergency measures that are designed to protect those vulnerable groups within the population. Well, thank you. I think that is the last slide. Thank you, doctor. Now, please, Dr. Manuel Cervantes, you will have the floor now. Please do share with us different measures that have been applied by the Institute to. Thank you very much. First of all, good night to all of you. Of course, the National Institute of Social Security, in cooperation with the Secretary of Health and likewise institutions, we're implementing a strategy that at its core has the realization that possible patients and infected cases with COVID-19 to try to avoid attending physically to the hospital unless it is necessary. So we've been providing telephone assistance and remote assistance to determine whether the patient is in a situation that merits him going in person to the hospital. I would like to show you a presentation now. We will be supporting our patients so they don't have to expose themselves to hazards like public transportation or being in confined places while waiting for a checkup, or being exposed at waiting rooms, for example, within clinics, especially older people who are more vulnerable. We have another objective, which is to become more efficient, have more efficient infrastructure and facilities, so that we have provide more efficient care to our patients and reduce the amount of times they have to physically present themselves at the hospital or clinic, or in a more expedited manner just go to pick up their prescription and to fill their prescriptions, and then they can go home. As you can see, we have been implementing such measures through an electronic system in which many of the steps are automated. Now here we can see there are 4 prescriptions. You have one is a copy for the patient, and then we have the prescription for first month, second month, and third month. And then what do they do at the drugstore? Well, today I'm gonna fill my prescription for today. Then the second prescription, a neighbor, a friend, or a relative can go to the drugstore and then to the pharmacy and then submit this paper to the drugstore, and then the drugstore will confirm that the documentation is correct and then fill the prescription. Now the third month they can go again, and then a similar documentation confirming process is carried out. So all of the patients that have chronic diseases and are within the 19 pathologies that conform the second level, as we have defined it in the past, they should minimize the risk of exposure to the virus. So we have designed special policies to give care to these patients in a controlled manner and make sure they can fill all of their prescriptions. Well, I will stand now, if that's okay with you. As you can see, videos can have a lot of information in them, but if we don't implement actions to go with these videos, then the effect will be not the one we desire. So as you can see, we have been facing challenges every day, all of us, and that includes us. For example, our program of refillable prescription, basically we give the patient one checkup and then we give them separate prescriptions that will last for 3 months. But the purpose of this is they don't have to go back in person to the hospital to fill their prescriptions, but they can send after the checkup. Next time they have to fill their prescription, they can send a relative, a friend, and then they don't have to be exposed. So basically, the objective of this program is so vulnerable populations don't have to go in person to fill their prescriptions. Now we have a list of several like chronic diseases or chronic conditions whose victims or sufferers should not have to go in person to our clinics or hospitals, but once every 3 months. So we've been filling a lot of prescriptions all the way from 2013, and look at what happened. Look at what happened. A lot of relatives, friends of these patients, they made a commitment and they said, I would rather stay home and send my friend, my relative, my acquaintance to go and fill my prescription for me. We can see that commitment. That commitment made by the patients. Why healthy people hasn't made such a commitment yet? This is an open question for society. Now we have another high risk factor group, which is pregnant patients. We have to take care of our pregnant patients and do not expose them to unnecessary risks. So these pregnant women will require a certificate of incapacity, and just by filling a small number of documents, they can avoid exposing themselves to unnecessary health risk. Now, on our first level of attention or of care, we usually take care of our pregnant patients at least 5 times before directing them to their birth patient. So all of those patients that have prenatal vigilance, that have the benefit of such consultations outside of the institute, well, so they can do this outside the institute as well. They can go to a private doctor and fill out the proper documentation and gather all the signatures they need. So this is all to provide access to their incapacity certificates in a comfortable manner for them. Now, in order for our patients to stay at their home, be able to stay at their home, but still manage any cause of concern they might experiment, we have telephonic assistance to So this via telephone assistant has the purpose of redirecting the patients properly to the relevant institutions that will provide healthcare for them and determine if it is safer for them to stay home or should they need to go in person and receive medical care. We've been processing hundreds of to this day, just a few minutes before I came here, we had processed over 5,000 telephone requests for informations and medical consultations. So I would like you to rely on this service because when you call this line, you will receive medical expert consultation and attention regarding any symptoms that you might be experimenting. Here we have the orientation line. You can call this number 800-222-2668. When you call this line, you will receive specialized attention by a qualified medical professional. When should you call this line? Well, first, when you think you may have been infected with COVID for any reason, just have suspicions of it. Yeah. When calling this line, they will tell you when you should go in person to a medical unit or when should you not. Who will be sampled? Well, there are also strict parameters that indicate who is a candidate for a test and who is not a candidate. And last but not least, well, you will be informed with the alarm signs or like high alert signs for COVID-19. So these are some of the measures that we at the Mexican Institute for Healthcare been implementing to fight COVID-19. Thank you so much, Doctor. We will continue a little bit later in a question session so you can go into further detail regarding these measures and especially when talking about vulnerable groups like pregnant women that are the ones that have a higher risk of contagion. Now please, Dr. Eduardo Robles will have the floor shortly, but I would like to say something first. Yesterday there was a colleague who asked us a very specific question. She asked if we had identified cases of COVID within the workers of the health sector, and I referred a case in Monclova, Coahuila, which is true. As we speak, there are 17 cases of health sector workers that have been identified as COVID confirmed cases, and that is true. But yesterday I mixed a little bit the elements and I attributed the causes of this infection to a private consultation, and I would like to apologize to the state of Coahuila, to the governor. I have already apologized to the governor and to the inhabitants of Monclova that were upset about this comment. So the confirmed cases are true, but they should not be attributed to the local conditions of health treatment. So my mistake. Right, doctor, now you will have the floor. Please tell us a little bit about what you have prepared for today. Thank you very much. I would like to talk to you about how is the situation within health sector workers. at the IMSS. So far, we have 39 cases, confirmed cases, out of which we have 3 deaths. These 3 cases we have not been able to confirm that has been work-related infections. The research we've done so far has showed that it was the contagion that happened in these cases was not within the workplace, was through an external means. One of them was through a family contact, the other one was an already retired worker, and obviously, hence, the source of contagion was outside of the institute. Now, what happened in Coahuila? In Coahuila, we have 21 confirmed cases reported so far. We haven't had any deaths. Most of them are walk-in patients. So, basically, in Coahuila, what happened is, so far we think the primary source of contagion were other doctors. But especially 2 doctors. So what it is a fact is that starting with these 2 confirmed cases, these 2 doctors, they infected another 19 cases, and that was the way the virus spread within this specific situation. But what I would like to say right now is that the fact that we have a confirmed case within any hospital does not necessarily mean there is an occupational hazard within that hospital. Just like the law, the federal work law stipulates, an occupational hazard will be determined if the source of contagion was within working hours, within the working place, and because of the working of the activity or work-related activity. So far, with these cases, we have had not sufficient elements to state that this was an occupational hazard, and we continue to investigate and to analyze so we can determine whether in Coahuila we should or not judge it an occupational hazard. But we will continue within this process. Tomorrow I will be presenting myself in Coahuila, and we'll have a press conference so we can talk in more detail about the strategies that should be implemented regarding health measures, sanitary policy within the Monclova's number 7 hospital, which is the one that we are talking about specifically right now. So, doctor, just for you to know, we have in this hospital in Monclova, Coahuila, we have identified the 2 source cases, and we are working towards determining the specific confirmed source of contagion. Thank you very much. Finally, I would like to ask Dr. Gustavo Reyes Terán to share with us some information about the clinic investigation that the IMSS is currently working on regarding COVID. Thank you very much. The scientific investigation group that I'm in charge of coordinating is currently finishing paperwork to initiate the implementation of 5 clinical trials. These 5 clinical trials are using medicine that has been proposed on an international scale, that are medicine that will potentially have an effect to control or mitigate the effects of the virus, and maybe even help slow down the transmission rate, attack the symptoms, and maybe most importantly, avoid any fatal and any severe complications, and if there are severe complications, to rescue those patients from a fatal outcome. So as I said before, these five medication, first remdesivir, then hydroxychloroquine, second, third hydroxychloroquine and azithromycin combined, and then in fourth, tocilizumab. It's a little complicated, but it's an but this medicine would have the effect of avoiding systemic inflammation within the tissue and preventing pulmonary damage and other organ damage. And the purpose of this last medication is to mitigate any damage that could be presented. And lastly, there is a method that's called plasmapheresis, which is the obtention of the gathering of plasma, of blood plasma, of patients that have been severely ill but have recovered. So we could maybe take that plasma and transfuse it to people who are currently dealing with the illness. So these 5 clinical trials are currently about to be approved. We are finishing the last steps of the paperwork, and remember the reason for these clinical trials is because we can never use a medicine just because someone said it would work. We have to make it safe for the population. We also have to submit the usage of any new medicine to an ethics committee and also to a biosecurity committee. All of these measures are to avoid these medications to have any damage or pose any risks to the population's health. So some of these medicines that I have talked about, we have recorded evidence that they are not non-prejudicial. So that opens the door for clinical trials to be conducted. And we can test their effects in populations that are in a... Well, we have 3 clinic essays that have been approved by the ethics committee so far. Hydroxychloroquine, tocilizumab, and a third one. So as we know, there is an incubation period for COVID that lasts approximately 5 days. Then the next stage, the virus starts to become apparent in the tissue throughout the body. Then we have fever, we have a cough, and it also leads to a general inflammation of the human organism, and this could lead to pulmonary tissue damage, and this could also be clinically expressed through respiratory insufficiency. So as we know, respiratory insufficiency is a sign that that person should be provided with hospital care right away. And then, as we know, if the complications continue, the inflammation could lead to death. So these experimental treatments can be initiated at an early stage and an intermediate state and a later stage. So we are proposing to use hydroxychloroquine in early stages and intermediate stages, and the second medicine in more severe stages of the virus. The other two protocols, especially the plasmapheresis protocol, that one will be submitted to ethics committee so we can know whether it is approved or not. It will probably be approved, and then we can start working with it. That would be the synthesis, doctor. Thank you. And I would like to add to what the doctor has said. The, the population should under any circumstances, should not assume that these medications we have been talking about have been proven to be useful to attack or combat the virus. This should not be assumed. This is medication that is under clinical research, so we can some of these medications are already currently being used for other diseases, but we haven't reached a consensus, and we haven't reached a conclusion that this medication should be used to treat COVID. So please do not make assumptions. All right, we'll start taking some questions from the audience. Tomorrow. The ones who didn't get to ask today will get to ask tomorrow. Thank you. First of all, about the recovered patients, I would like to talk also about how many people have recovered so far, because I think we haven't been seeing a lot of data regarding that. Because we don't really know how many recovered patients we are dealing with so far. Could you prepare that information for us? How many men, how many women? Have all of them been tested to verify that they have recovered? Or how do they know they have reached the status of recovered patient? And also, after the 14 days of isolation, is that it, or are any other periods of isolations needed? Please answer that too. And I would like to ask you, talking about these phone calls you've been receiving, that you talked about, the over 5,000, how many of these over 5,000 calls that you've been taking at the institute are actually cases, probable cases? Because there are other services in which they tell them that they will call them and tell them where to go and what to do, and those calls have not arrived. And talking about the curve, the pandemic, I would like to know, with the healthy distance measures, we will flatten the curve, right? That's the goal. And then April the 30th, we will determine whether the curve has flattened or not, and then we'll know if we have to extend the period of healthy distance measures or not. So how flattened has the curve is the curve supposed to look in order to know if we extend the period or not? Yes, I will take that. So as we enter the second stage of the monitoring of the virus, called Sentinel stage, we also have made modifications to the online databases and communication system. And these databases are updated by each state authorities. So the migration between the two different systems has led us to a period of validation of information. That is why we don't have more specific data about the recovered cases so far, but no problem, we can prepare an estimation and we can bring it tomorrow to show it with you. And we can present that information to you tomorrow. And once a new platform is operating 100%, then we will be presenting that data on a daily basis. Yes, I will answer the one about the telephone calls. So, out of the 5,000, 4,000 are related to respiratory diseases, not exclusively COVID, but part of it. And only 7 patients showed alarm signs and they were canalized to a second stage of treatment. And then, talking about the third question, what does to flatten the curve mean? What it means is when we show these graphics with charts that we've been presenting to the populations, the amount of cases that are confirmed doesn't matter if they are how severe, but we can see that there is this curve that we have presented. Yes, maybe visually it will make more sense to talk about this. So the curve, the epidemic curve, it's a technical term. So here we have the days. Each dot is a day, and then each day we have the number of cases that is presented on the vertical axis. So we have 0, 0, 0. Then we have on the February 27th we have the first case. Then here we have the first case, 2 cases, 0, 0, 0, 3. March the 13th we had 11 new cases, and that's where we made the announcement that the pattern was changing. That was a Friday afternoon. Then we had 14, 14, 20, 20, 40, 45, 60, 65, 100, 110, etc. And that is the speed in which this epidemic is changing within our country. So that is the infection force, let's say, so to speak, the vigor in which we can measure the amplification of the epidemic. What we want is for this strength, for this speed to slow down. So what we see here, it's like each chunk of the curve means the daily amount of new cases. But to flatten the curve means to reduce this inclination. Now, by how much? We don't have a pre-established goal. The ideal will be 0, but we know this is impossible. So any improvement we can do on this regard will be seen as a success of the healthy distance measures. Obviously, because this is a new disease and a new epidemic, there is not a preset amount or goal. After 14 days have gone by, in average 7 days after the mitigation measures, we will see changes in the inclination of this line. And this will be a success, not of the government, it will be a success by the society, by the Mexican people who will have stayed home and they will have reduced the amount of contagion. So this measure started March 23rd with the closing of schools, and that means nearly 15 million people stopped going out to the streets on a daily basis, including teachers, students, parents, people who sell at schools. That's in total 15 million people. Now we have the other measures that we haven't that we were talking about yesterday of staying home that have been successful to a certain extent, but we still have a way to go. So there is a point in which the change in speed will be so important that new measures will have to be necessarily, and these new measures would not be favorable for public life and probably not too useful either. But we want to state that we've been preparing for phase 3 since January. So everything that we talked about yesterday will play a major role in the outcome of this pandemic. We have 10 minutes to go. Hello. This morning you talked about the non-essential activities that will be suspended temporarily and the essential ones. These generated a lot of questions because, especially in Coahuila, regarding the mines, because the mining activity is seen as essential to a lot of local people. Are mining activities gonna be stopped as well? Yes. A few minutes before coming here, I was in a 2-hour meeting um, with the Secretary of State and with the 32 governors of Mexico and many different authorities on many different levels. And one of the topics brought up by the governor of Coahuila and the governor of other mining states, they expressed this concern. And the answer is the following. Mining is obviously one of the important economic activities of Mexico, just as the construction industry and other important industries. We don't want to stop the mining activities. The idea is that the public life overall wouldn't stop. But we have to be absolutely realistic. And we have to be very aware of two elements. One of them is we have an epidemic and we don't want it to propagate rapidly throughout the territory. If that happens, we're going to have too many cases, too many sick people on stage 3, and it's going to overflow the capacities of our medical institutions, and that will affect severely the life and the health of everyone. We don't want that. We also don't want a diminishing economic and social activity because that will have a direct consequence on Mexican families. We know that a large portion of Mexican families live in poverty. And we don't want to affect those people, including the people who work at the mining sector. So we have to reach an equilibrium point. And the equilibrium point cannot wait anymore. And that equilibrium point is precisely being expressed through the measures that we announced yesterday. And these measures were not taken arbitrarily, were not decided arbitrarily. They were the result of a consensus, of a long process of analysis and expert input. It is a limited time frame we are dealing with, 21 days. Now, talking about the artificial breathers, we've heard that there's not enough artificial respiratory devices, and you are currently looking to buy them outside. But we have a lot of national innovators, entrepreneurs, scientists that have developed prototypes, and they're only waiting for the approval of local entities that follow international standards so they can begin mass production. Yeah. And there are people who are very willing to even do patent-free devices, so that we don't have to wait for international response to buy them from outside. We, because the main goal is to save lives. All right, yes. Give them, please put them in touch with us. We have no resistance whatsoever to these alternatives. We're exploring all alternatives. You're talking about these innovators, these scientists, these developers. Please put them in touch with us so we can explore that alternative as well. I want you to be aware that all of the secretaries of state, all of the local governments are coordinated and are working together as a team with the federal government to defeat this together. We have a very specialized team with the very finest specialists within our country and international as well, from the public sector and the private sector. And the purpose is to have this highly specialized group to analyze these possibilities and know how possible it is for us to start making mass making and mass producing these devices within a very short time frame. So please put them in touch with us, and we will see that it is resolved. So anyone who knows any person or institution or group that has a real possibility of addressing this issue, please put them in touch with us. Good evening, Jocelyn Arredondo from Notimex. Now, with this health emergency statement that we saw yesterday, are we going to be closing any public beaches? And then a lot of people are complaining that you stated that they could leave their workplaces and enjoying their salary, but apparently this hasn't happened in some cases. Yes, I would like to tell you, when we have been meeting with the 32 governors and chiefs of local states, there's been a very productive conversation with them, and I'm very satisfied with the way we have been cooperating and sharing information. And one of the concerns regarding the states that have a lot of tourism was related to the beaches, and we had to reiterate that we have given the order already, and the order is to stop any activities in public spaces, that any public activities that involve more than 50 people, and that of course includes things as beaches. So of course we will be expecting for local governments and administrations to abide these new regulations and adopt the relevant measures in tourist places, including beaches. And regarding the second question, the sanitary or the health emergency state we declared is by force majeure causes. So, according to the law, this is not both. It is not allowed for workers to go, non-essential workers to go, to continue to go to work on a daily basis, but also it is not allowed for the businesses to just end the working relationship with them and stop paying them because of this emergency. So that's the law, and the statistics and the public services that are at the disposition of workers to talk to them about their rights, so they don't see their rights affected by this. So I would like to call for all of the private companies. This is a national challenge, that we have to take collectively. So big companies, middle-sized companies, small companies, small businesses, do your due part, please, so we can do your part in this fight. Do not affect your workers' rights, and maybe we can, and we will defeat this virus together. Okay, this will be it because there's only 1 hour. We have limited time. Thank you very much. See you tomorrow, April 1st.